share my screen here. Hang on one second. Okay, can you guys see the PowerPoint? Yes, no? Yes, okay. All right. So the first topic that you guys struggled with the most was JIA. So juvenile idiopathic arthritis, it's also known previously as juvenile rheumatoid arthritis or idiopathic arthritis of childhood. There are some different potential causes. Some environmental trigger in utero is a potential, and then immunogenicity. So an immune response that kind of makes them more susceptible to getting JIA. Usually onset between the age of 1 to 3. It's often misdiagnosed or undiagnosed. So you might see this in an older kiddo later in life being diagnosed after they've continued to have joint pain. So there's 4 different types. The systemic onset, which that's where you're going to have systemic symptoms. So you're going to have rash, fever, enlarged spleen, enlarged liver, pericarditis, pleuritis. So that infections in the lining of the heart and the lungs, and lymphadenopathy. So enlarged lymph nodes. Oligoarthritic, that's 4 or less than 4 joints. Polyarthritic is more than 5 joints. And psoriatic, that's either when they don't define or they can't differentiate between the other 3 types, then they might call it psoriatic arthritis. Or if it's enthesitis, which is inflammation of the entheses, so like on the joints. Okay, about 90% have negative rheumatic factor, so negative ANA. Okay, these kids, symptom-wise, they're gonna come to you. They're gonna be typically usually really active kids, and then all of a sudden they're starting to refuse to do things that they usually want to, and that they enjoy because of the pain and the inflammation and the swelling of the joints. Okay. You guys can read the rest of that. There's no definitive diagnostic tests. However, some can kind of clue you in lab-wise to JIA. Elevated, so ESR, SED rates are usually elevated. ANA can be positive, but like I said, it's not always positive, and in most cases, it's actually not positive. Leukocytosis, okay, if they're in an inflammatory portion, okay. And then it's diagnosed based on criteria from the American College of Rheumatology. There's no specific cure. The goal of therapy is to continue to preserve as much function that they can have to be able to continue their activity, okay, and maintain that level of function, and to prevent deformities from those joints continuing to be enlarged, and to relieve their symptoms or improve their symptoms. Usually these kids are getting outpatient care, okay? Medications that are used, and NSAIDs, so things like Aleve, ibuprofen, meloxicam. They also do anti-rheumatic drugs and biologics and steroids, glucocorticoids, okay? Physical therapy and occupational therapy are usually necessary in kids with JIA. Obviously the goal for pain relief and pain management and promoting their general health. These kids can have other sort of, like they usually need to see an ophthalmologist because they have risk for uveitis, and other eye effects potentially. So making sure that they're going to all of their routine follow-ups, okay? And their typical well checks too, okay? All right, here's our case study. This is where I'm gonna have you guys start giving me some feedback, okay? So I'll read it to you first. Emily's an 8-year-old female who's brought into the pediatric clinic by her mother. She reports joint pain, stiffness in the knees and fingers, especially in the morning, difficulty getting out of bed, swelling and warmth around the joints, low-grade fever on and off in the evenings for the last couple of weeks, and fatigue with reduced physical activity. Okay, now we just talked about JIA, right? So that's clearly what this case study is, but we're going to try and figure out which type, okay? All right, your physical exam findings, you see swollen, warm, tender, bilateral knees and the PIP joints of the fingers, okay? Limited range of motion and morning stiffness greater than an hour. Tired looking, slightly pale, no rashes or lesions. 99.8 in the evening, otherwise vitals look okay. And then 25th percentile for height and weight. Anything that's jumping out to you guys on the physical exam? No?
Her temperature?
Yeah, low grade in the evening, right?
Limited range motions for that age.
Yeah.
Color.
Brittany, did you say something? Sorry, I didn't hear you.
Skin color, the slightly pale.
Yep, pale. Yep. What else? What else is abnormal?
Her height and weight are just in the 25th percentile.
Yeah, but if she maybe has been on that, is that concerning, that curve? It would be concerning if she hadn't been on the 25th percentile, but if that's where she's been, then it's okay. What about the musculoskeletal stuff? That's concerning, right?
Stiffness for more than 1 hour.
Yeah.
Swollen, warm, tender bilateral knees.
Yep. Yep. Good. And the PIP joints. Good. Okay. Here's our labs. Okay. Slightly elevated ESR. So that's your SED rate. Okay. Positive ANA. Negative RF factor. Okay. And then your x-ray, mild joint effusions. So some fluid swelling in the joints. Okay. Mild anemia. Okay. So what type of JIA is this? Were there more or less than 5 joints involved? Do you want me to go back to here's your assessment findings.
There's more than 5 joints involved?
Well, fingers, bilateral fingers. So fingers count as like one joint involvement, even if it's multiple fingers, but it's both sides. And what else?
The knees, 2 knees.
Bilateral knees. So how many
4
points? 4. So do you remember back which type of JIA would that be? 4 or less is let's go back to the types. Oligoarthritic. Okay. So oligoarthritic JIA is the type we're dealing with here. Okay. Okay. All right. What are some nursing diagnoses to go along with JIA? What are some things you need to be thinking about as nurses?
Pain management,
Yes. Yep.
decreased
Physical
mobility.
mobility.
Yep. Impaired mobility. What is your related to for that?
Stiffness, morning stiffness.
Inflammation.
Yeah, related to like joint inflammation and stiffness,
Yeah.
even like chronic pain due to
Yep.
inflammation process in the joints.
Yep. Now these kids are gonna likely be on steroids pretty long term. So what can steroids do to people, especially children?
You're immune.
Sorry, I didn't
Cause
hear what you said.
swelling.
Is it body imaging issues maybe because from the
Yep.
weight gain?
Yep. Body image would be an option. Yep. But what do glucocorticoids or corticosteroids do for
They
kids?
stop the adrenal glands from producing kidney, so we risk Addison's crisis.
Mm.
Yep.
Elevate
And
blood sugars.
increased risk of infections.
Yep. What
Does it
about on
elevate?
growth? On a kiddo's growth.
It suppresses the long bones, right?
Yes. So their growth is going to be affected too, potentially. Good. So altered growth and development because of their symptoms and medication side effects, right? That'd be another one. Good. All right. What are some nursing interventions you guys are going to do with these kiddos with JIA? Just throw some things out there. How are you going to take care of a kiddo with JIA?
Rest.
Sorry, Brittany, I didn't hear what you
Rest.
said. Rest. Yeah.
Encourage like weight bearing exercises.
Yep.
And weight bearing exercises, calcium, vitamin D supplements, possibly.
Yeah, if they're low or deficient
Don't
in
stop
that.
your corticosteroids. Follow the regimen.
Yeah. What about for pain? Are you guys going to be giving them meds for pain? Probably, right? What about a warm bath in the morning to help with their morning stiffness? Do you think that would help? Yeah. What are you going to be teaching? The family and the child.
The symptoms to look out for.
Yeah, it's like a flare up, right?
How to take their medication, like if you need to taper steroids or when to take it, give it with milk, or just to prevent stomach upset because it can cause stomach upset.
Yeah. Yeah, and with steroids, when do you take them?
Same time every day.
Okay.
With food
What time of day usually?
in the morning.
Yes, because what can happen if they take them at night?
They'll keep them
It'll
awake.
keep them up.
Yep, exactly. Good. All right, good job, guys. All right, next topic was biliary atresia. We struggled with this one too. So also called extrahepatic biliary atresia. The etiology is kind of unknown. Typically, these babies are pretty healthy at birth, but then jaundice just never kind of goes away. It's diagnosed by your clinical evaluation and getting medical history. Okay, so how the kiddo looks, they're going to have jaundice that's prolonged, maybe an enlarged liver on an exam that you can feel. Usually abnormal stool colors and then difficulties with feeding. Blood tests to look at liver function, bili levels, and then clotting factors to check for any bleeding risks. Okay. And then imaging wise, usually an ultrasound to visualize the gallbladder and the bile ducts, which then that's where you'll see that narrowing. Okay. That's the biliary atresia. So the narrowed or blocked bile duct. Okay. And then some kids will get cholangiograms, which is an x-ray of the bile ducts specifically. Treatment plans for biliary atresia, medical wise, making sure that they're getting their fat soluble vitamins because they do not have great absorption of the fat soluble vitamins because of the biliary atresia. So they need ADY or ADE and K for supplementation. They're going to be on high calorie formula, or if breastfeeding, they're going to be mixing it to a higher calorie. Okay. You're going to be monitoring liver functions tests, and these kids will usually have a Hesi procedure, they call it. So essentially what happens is where that blockage is, they in the bile duct, they cut that and then attach it to the small intestines, and then attach off the bile duct the stomach as well to that area. And usually that's completed before the first 60 days of age. Okay. If left untreated, these kiddos are going to have liver cirrhosis. Okay. All right. Case study for biliary atresia. 6-week-old female was brought into the pediatric clinic by her parents for complaints of persistent jaundice since birth, which has been worsening in the last couple weeks. Pale clay-colored stools, dark yellow urine, poor weight gain, even though she's eating well, and occasionally irritable and fussy. Okay. Okay, here's your physical findings. What seems abnormal on your physical assessment?
Jaundice, skin,
Yeah.
lethargic,
Her enlarged liver.
Yep.
Tea-colored urine.
Yep.
The stool.
So
Yep.
the weight,
Yes. Below the 10th percentile for age, because the parent said she's been eating well, right? But she's not gaining. So that's where you get concerned about the weight. Good. All right. What about these labs? So you have your normal ranges on this side, okay? What are you seeing over here?
Oh, her
Mhm.
bilirubin.
Yeah. Her total and her direct, right? So
Mm-hmm.
that's telling you that the liver is not working.
Nor are her liver function tests.
Right. Right. Yeah. And GGT, so that goes along with the liver too. They couldn't visualize her gallbladder with the ultrasound. Okay. Her HIDA scan. None of the tracers got into the intestines, which is telling you there's some sort of blockage. Okay. And then they did a liver biopsy, and that showed portal fibrosis, peripheralization of the bile duct, which is essentially showing you that there's some sort of blockage in the bile ducts. Okay. And like we already talked about, treatment for that would be surgery and medical. Okay. All right. What are some nursing diagnoses that go along with biliary atresia?
Impaired nutrition.
Yeah. What's that related to? What's your rationale?
Oh, God.
Obstruction or absence, right?
Sorry, what did
see.
you say?
nutrition,
Obstruction or absence of bile ducts would be the related reason.
Yeah.
the nutrients aren't being
Because they're not absorbing their fats and their nutrients
intestine.
appropriately.
Yeah.
Yep. Yep. What would be your intervention for that?
Monitor daily weights, provide like high calorie formulas.
Yep. Good. All right. What's another nursing diagnosis? So they're going to have surgery. So what would be something else you would be concerned about?
Whisper infections because of
Yes.
white blood cell counts.
And elevated jaundice
Okay.
for longer periods of time that plus then surgical intervention, that puts you kids at even more increased risk.
What about failure to thrive?
Sorry, Brittany, I didn't hear you.
What about failure to thrive?
Yeah. Yep. What else? So this is a 6-week-old baby, and they have to have all this intervention when they're so little.
Oh, parental anxiety.
That's a good one too. But what about bonding? Impaired
Mm.
parent-infant bonding, right? That would be a risk too. Yep. Good. So what would be some interventions if you were concerned about parent-infant bonding or parental anxiety? What'd be some things that you could have these parents do?
You could definitely educate them
Uh-huh.
with, somebody who maybe more of a specialist, just to like ease their anxiety, to show like, hey, you're not gonna, like, just because A, B, and C is happening doesn't mean that the bonding process doesn't still have to begin, and all of that.
Yep. Yep. And you can
Maybe include the parents in the patient care while we're
Yes.
going through this process, so that they don't
Yes.
feel like they're disconnected.
Yes. Good. Great. All right. All right. Nursing interventions, we kind of already talked about. Monitoring for infection. After surgery, what else are you going to do?
Check for
What's up?
bleeding.
Uh-huh. So monitor your surgical site. Yep. Sterile dressing changes if you're doing those, right?
Pain management.
Pain management.
Airway.
Shelby, can you turn your camera on? Sorry. Yep. Good. And then, like you already said, educate the parents. Good. Okay. The next topic that was the struggle, it was hypoparathyroidism. Okay. This was pretty much across the board for all of you guys, a struggle. Okay. So there's a specific deficit in parathyroid hormone, the creation of parathyroid hormone. Okay. Usually from an infection or an autoimmune syndrome, or DeGeorge syndrome. Okay. Or after having your thyroid removed. Okay. Sometimes while moms are carrying babies, they have hyperparathyroidism, which then that will cause hypoparathyroidism in the kiddo, or if mom has diabetes. Okay. Or if they're taking a special formula with a higher phosphate to calcium ratio. Okay. What you're going to see in hypoparathyroidism is dry, scaly skin rashes. Okay. Brittle hair, thin nails. You're going to see those transverse grooves, so those lines across their nails. Okay. Tetany. So the muscle twitching and paresthesias. Okay. You can see laryngeal stridor or spasms, okay, because of all of the electrolyte imbalances that are going on, okay? Headaches, seizures, depression, confusion. It's diagnosed based on your symptoms and low plasma parathyroid hormone. Your goal is to maintain their calcium and their phosphate levels, okay? You want to immediately correct tetany. These kids will need vitamin D therapy. Okay. Blood work wise, you're going to look at renal function and blood pressures and serum vitamin D levels. Seizure precautions are important, and then monitoring for laryngospasm because of the potential electrolyte imbalances. Okay. All right. Case study. Liam's a 10-year-old male with a history of DeGeorge syndrome, presents to the pediatric emergency department with complaints of tingling in his hands and around his mouth, muscle cramps, and difficulty breathing. Okay. Here's your physical exam. What's abnormal in there?
Loki sign.
Chopsy sign, yep.
Trousseau
Yeah.
sign.
Trousseau sign, yep,
The mild wheezing on an auscultation.
yep,
Anxiousness.
yeah. So Chomsky sign, do you guys remember what that is? Like, you tap on their face and they start having a face muscle contraction of their cheek. And then Trousseau sign, you're getting their blood pressure and they have spasm of their carpal, so their wrist spasm. Okay. All right, here's your labs.
Calcium.
Is
That's what's
what?
called.
Phosphate.
And remember, calcium and phosphate in deficiencies, they're already always going to be the opposite. Okay. So it's always going to be low calcium and high phosphate.
Magnesium's low.
Yep, just a little, right? What about the parathyroid hormone?
It's low.
Low because it's hypoparathyroid, right? And then what about their vitamin D? Kind of low normal, right? Okay, good. All right. So what are some nursing diagnoses for kids with hypoparathyroidism?
Risk for injury due to neuromuscular.
Uh-huh. What did we talk about on the first page?
Oh, the irritability because of calcium, low calcium.
Uh-huh. Which would be concerning for what?
Muscle spasms and seizures and stuff.
Seizures. Yep. Yep. Exactly. Good. So, what else? Oops, sorry. What would be another nursing diagnosis? You think these kids are going to be very good eaters? Probably not, right? Usually these kids have poor appetite because of their hypoparathyroidism, okay? Because of their muscle spasms that can come into effect as well when they're eating, okay?
So would you give them a bunch of small meals?
Yep, smaller, probably more frequent. Yep. Yep. Good. What about parents? Are there any nursing diagnoses related to parents or the child too?
Like just a knowledge deficit,
Yep. Yeah.
just not knowing how to actually, I don't know, progress in the disease to actually help their child.
Yeah, and manage it by talking about the importance of their calcium and their vitamin D supplementation, right? Because that's probably going to be quite a struggle. Good. What else?
Is
What about-
airway an issue too?
Not necessarily. I mean,
Necessarily.
it can be, but not necessarily. It's more related to an imbalance that I'm trying to get you guys to say. Risk for electrolyte imbalance, right? Because of the low calcium. So having low calcium prolonged, it can affect not only your muscle function, but what else is a big muscle that it can affect?
Your heart.
Mm-hmm. Yep. And your nerve conduction, right? Good. Okay. All right. Now some nursing interventions for hypoparathyroidism. What are you guys going to do as nurses for these kids?
Vitamin C and D supplements therapy or vitamin C and D therapy.
How about calcium and vitamin D? Vitamin C is not so important in this one. What about if their calcium's really, really low? What would you do oral calcium or IV usually?
IV.
Mm-hmm. And then what other electrolytes are you watching?
Phosphorus.
Uh-huh. And what else was a little bit low? Do you guys remember on the labs?
The magnesium.
Yep. Yep. So those would be the 3 electrolytes that you really want to focus in on with this diagnosis. Okay. What else would you be teaching parents to look out for? What about some signs of hypocalcemia? Which would be what? Do we remember back to our physical assessment findings? So Chotsky's sign, Trousseau's sign. Now they won't be able to do Trousseau's sign, but you know, they might notice that tetany of the muscles, right? So teaching them that if they're seeing those things or seeing muscle cramps or tingling, paresthesias, that they have to get concerned that their kiddo's calcium is low. Okay. So they'd have to have their kiddo be seen. Okay. Anything else? I'm gonna stop my share here. All right. Questions, concerns, thoughts? No? Yes? Okay. Thank you guys for a good term. Homework grades still haven't been turned on yet. It's what's showing is your KGA grade. I have to wait for everyone to be done with remediation before I can turn the homework grade on as well. Okay. So
Okay,
hopefully,
thank you so much, Ms. Becker.
yeah. So hopefully by tomorrow, your grade should be in there. It should be homework and everything added in. Okay. If you're seeing something that looks abnormal to you in your grade and you feel like something happened and I misgraded it, you can definitely send me an email. Okay. Alrighty, good luck going forward to all of you guys. I enjoyed having you this term. Hopefully you all decided you like peds a little bit more maybe than you thought you would. That's
Thank
always
you.
my goal. Okay, yep, see you guys later.